Hello, everyone. Thank you for joining our final webinar in our three-part webinar series on how to pandemic-proof your practice, hosted by AAOM, Regenix, IOF, and Doctor.com. We've had a great time with these webinars and educating a lot of you out there. Our first webinar was on telemedicine. Our second was on building a thriving cash pay practice. And then today, we have a special treat. We're going to be discussing how to safeguard patients and staff and navigating PPE and the COVID-19 testing landscape. And with me today, I have Andrew Ittleman and Joanne Tremblay. And we're really excited to go over PPE and testing. I will pass it over to Andrew to introduce himself.
Good afternoon, everyone. My name is Andrew Ittleman. I'm an attorney in Miami, and I'll be working with you today to help you understand the landscape that we all find ourselves in following the declaration by the Secretary of the Department of Health and Human Services of what's called a public health emergency. And so what flows down from that announcement of the public health emergency is the creation of the emergency use authorizations that you may have heard about. So we'll talk about some of the tests and other medical devices and supplies that are created through that process, or at least put out onto the market through that process. And we'll also be talking about some best practices for getting your practice back up and running after a protracted shutdown. But thank you, everyone, for having me. And I look forward to speaking with you and answering any questions that you have.
Hi, everyone. I'm Joanne Tremblay. I'm the principal and founder of Plymouth Medical. As the COVID-19 pandemic is really sort of developed over the last 6 months, our company's done a lot of research on the subject, and we've really tried to provide our clients with up-to-date information on the best practices to help them navigate this new world or new landscape. There's a lot of information out there right now, and we're getting it from all angles. We've all read very conflicting news reports. We've read conflicting studies on testing and PPE. So the purpose of today's webinar is really to try to make sense of all of this noise, and so we can help our clients emerge from this quarantine safely and conscientiously as possible. I'll be focusing today on mostly diagnostic and testing methods for COVID-19 that are currently available. We'll outline how they work, what their strengths and their limitations are at the present. Our team at Plymouth Medical has basically prepared a pretty comprehensive COVID-19 resource guide, which is available on our website at plymouthmedical.com under the education section. It's available to all. This document really covers most of the topics covered here today. But again, please understand that while we've spent a lot of time and poured a lot of research in these topics for you, this area is really evolving at breakneck speeds, both in terms of the regulations as they come out and the testing capabilities. So we really do our best to sort of keep on top of it and keep relevant and accurate.
Thank you so much. And Andrew, before you dive into the agenda, I just wanted to remind everybody, we do have poll questions. We would appreciate if you can answer those. And then if you have any other further questions, please type them in under the questions drop down. Thank you.
All right. So again, there are some important areas of focus that we're going to make our way through this afternoon in this discussion. There will be some give and take between Joanne and I. And again, if you have any questions, please feel free to raise them, and we'll do our best to answer them to the extent that there's that sort of information available. But anyway, we'll start from the top down, helping you understand exactly what an emergency use authorization is, and then what it isn't. And we'll talk about some of the products or the classes of products that have received these emergency use authorizations so far, and perhaps what to expect in the future as this program continues to unfold. Next, Joanne will primarily focus on what your testing options are today, and but that will also be covered a little bit when we talk about the emergency use authorizations that are out there for some of these diagnostics and the other types of tests. And then finally, we'll talk about getting back to work and the steps that you can be taking now, whether you're preparing to open or whether you've already reopened and you're trying to understand, what's best for your particular type of practice, given the type of office space you have, given how many employees you have, given the condition of some of your patients, et cetera. So we'll do our best to make it through all this content. But starting from the top, again, this notion of the emergency use authorization is relatively unique. What needs to happen in order for this emergency use authorization to be triggered is that the Secretary of the Department of Health and Human Services needs to announce or declare that there is a public health emergency. And once we have that public health emergency, it's the FDA's job under federal law to get products out onto the market that can address that public health emergency as quickly and efficiently as possible, but keeping in mind that there are still, safety and effectiveness obligations that the agency will still have. But rather than studying safety and effectiveness in an absolute sense, the way that the FDA ordinarily does, what's written into the statute is that, first of all, products that receive these emergency use authorizations are not approved. And this is not an approval. And if anybody tells you that they've got an approved product to address COVID-19, they're not being truthful with you, or they don't know what they're talking about, at least as of May the 27th of 2020. But additionally, what's written into this statute is that it must be reasonable to believe on the FDA's part that these products may be effective in helping the agency respond to the emergency. So again, we're not talking about safety and effectiveness in an absolute sense. And if that's what you need as far as your medical products are concerned going forward, as you operate your practice within this pandemic, then these products are probably not for you. But what's related to these statute, or excuse me, to the primary statute, are other statutes that provide the users of these authorized products, again, not approved, but authorized products, with a certain level of immunity. The federal law recognizes that by virtue of the fact that these products don't go through the full gamut of the FDA approval pathway, well, then they're riskier than they ordinarily will be. But to incentivize practitioners to actually use them and to not be concerned about liability issues down the road, there are other statutes that provide immunity for the users of these products. And what has been created both now and in prior public health emergencies is an emergency fund. And so if a patient is injured by one of these authorized products, in all likelihood, subject to some obviously important exceptions, that to the extent that they wanted to file suit, they would be collecting out of that treasury fund as opposed to your malpractice policy or your pocket. So that should give you a little bit of comfort moving forward with these, I guess, quasi-regulated products. But again, what goes into the EUA application is not nearly the same as what you have when a product is going to file for, an approval. These are very different animals, and the EUA application is designed to move much more quickly. But I will give a significant amount of credit to what I've seen from FDA so far in terms of their interactions with product manufacturers and developers. They're open for business. They want to hear from you if you've got a product like this. They will shepherd you towards the right office, towards the appropriate sub-office within that office, and they'll make sure that you can get the information that you need to help them, fulfill their obligation of getting these products out onto the market. There's a guidance document from 2017 that sort of lays out what the process looks like. FDA is going to want you to include a thorough description of the product and the indication. that it's going to be used for. They're also going to want to see the approved labeling. They'll want to see fact sheets for healthcare providers, for patients, et cetera. And they're really going to want you to be able to establish that there's an unmet need that'll be met or satisfied by the product that you have. They're subject to some important exceptions. They're not going to be approving the same thing over and over again, unless it's something along the lines of the diagnostics, where you're seeing a lot of similar tests getting these clearances or these authorizations, simply because they want to get so many of them out onto the market. But ultimately, again, they are being flexible. They're in a substance over form mode. That is the agency. They want to see what you got. What's the data that you have? What's the substantiation that you have that's going to tell the FDA how your product is going to meet an unmet need? And from there, you can really rely on them to shepherd you through the process towards the authorization. Now, when we're talking about these emergency use authorizations, understand that there are a lot of different types of them. So we've seen general emergency use authorizations that can apply to entire classes of products, typically where they're low risk and they're not necessarily making COVID specific claims, gloves and gowns, things along those lines. And then there are specific emergency use authorizations that FDA is publishing on a product by product basis. And in order to understand exactly what's out there, it's best to refer to the FDA website. There's it's a fire hose of information on their emergency use authorizations page, and you can see how they're breaking all of this down. You've probably heard in the media about emergency use authorizations for different drugs that are out there, from Desivir and hydroxychloroquine. A lot of questions about those, the viability, the safety, etc. So understand that for those drugs, and we're not going to spend a lot of time dealing with the drugs today, but there are real restrictions in terms of how you can purchase them, how you can use them, and the data that you need to be recording to the extent that you are. We'll talk also about some of the other EUAs that are out there for the ventilators, for personal protective equipment, and then these class of other medical devices, which I find to be very, very interesting. We'll get into that in just a little bit. Now, the regulatory history between March and today, it's been quite a bit. It's been a lot to follow. And if you're not watching the FDA on a daily basis, if not an hourly basis, it's very easy to lose track of everything that's happening. And with certain types of products, FDA has gone this way and that way and this way and that way. And so you really need to be getting this information in real time. But to FDA's credit, they're getting it out in real time. And really, it's just a matter of being able to keep up with it. So we've got, as of today, May 27th, excuse me, there are 49 guidance and policy documents that have been published. And there's guidance for really anything that you can think of that might be useful in combating the coronavirus or in preventing the spread or detecting the coronavirus. There's information out there that's for you. You can generally find the information just by doing Boolean searches on FDA's website, to the extent that, you're just not getting it or you're not grasping the context. Feel free to reach out to me, reach out to Joanne, and, we'll be happy to walk you through the process. But I want to keep going. I don't want to get lost in any of this stuff because we've got a lot of important information to cover. But understand, most importantly, that the regulatory history goes back to March. It's very, very confusing. And anything that I talk about now on May 27th at 2:14 p.m. could be completely superseded at 3:00 p.m. or tomorrow. So we got to stay on top of this and don't take anything for granted, at least as far as FDA's positions are concerned. So we'll start with the personal protective equipment. And again, for the PPE, there are general use EUAs that are out there for these. And if you look towards the bottom, of this slide, you'll see that there are general authorizations that are available for different types of low risk products, gloves and gowns and things of that nature, and face masks, face shields in certain instances. And so there you have these blanket waivers for them that lift most of the ordinary regulatory requirements that the manufacturers and distributors have. So for instance, if there's a Chinese made face shield, under certain conditions, the Chinese manufacturer will not have to register or list with the FDA, nor will the importer. This is just an example of the fact that FDA really wants to lower the bureaucratic hurdles that slow down the process of getting these products on the market. Now, for more sophisticated personal protective equipment, FDA is requiring the mother may I process between the manufacturer and the FDA. So for sterilizers and decontamination systems, FDA is going to want an EUA application for those types of devices. Face masks are broken down based on the extent to which they have been cleared by the CDC beforehand. The agency or the office within CDC called NIOSH. FDA is not requiring its own authorization if these devices, if these masks have these NIOSH approvals already. But there are many of these types of masks that have been removed from the process. They're typically foreign made, typically Chinese manufactured, and they have all the looks and features of the approved respirators, but based on everything that FDA has reviewed, they don't like what they're seeing, and there has been just a wave. There's 72 as of the other day that have been removed from the process, and you really need to be watching out for this again on a daily basis just to see what's out there and the extent to which FDA may have been removing certain of these masks or other personal protective equipment from the marketplace. Joanne's going to take us out as far as the testing is concerned. She's the expert there, and I'll jump in on an as needed or as requested basis.
Thanks, Andy. The CDC guidelines recommend the use of standard PPE precautions to provide essentially a barrier between the specimen and the provider during collection. So in that context, this personal protective equipment should also really apply in your patient procedures and even live consults if you suspect a patient may be positive. So the required PPE include eye protection or full splash guards, gloves, masks, either N95 or KN95 as outlined by Andy, lab coats, and disposable gowns. There's some considerations to be made on, when to remove those and when to dispose of gowns as well. In our next section, we'll basically be reviewing who gets the tests, how these tests actually work, where they can be used, what are the different test limitations and strengths, what are the current regulations, and where the test should be used, and really truly what if-then protocol should be followed. Commercially available COVID-19 tests currently fall in 3 specific categories. The first category includes molecular assays for the detection of SARS-CoV-2 viral RNA. The second category is called antigen testing, which really detects antigenic proteins in infected individuals. And thirdly, are serological or immunological assays, which largely rely on detecting antibodies, either IgG or IgM, produced by individuals as a result of their exposure to the virus. So, as Andy's outlined, the FDA is currently approving new tests using, they're not using like the normal approval channels. So no tests for COVID right now are actually FDA approved. They are evaluating validation data for tests under a new, or it's not new, it's an EUA process. Once they approve a test, the FDA will typically publish an EUA approval letter, which will clearly outline the indication for use, the source material or the specimen material to be used, and the collection methods. And they'll also outline and clarify authorized clinical settings in which the tests are to be used. Andy's going to talk to us a little more about CLIA and authorized settings in this context.
Thanks, Joanne. Yeah, this has been really the subject of a lot of confusion and really consternation amongst the medical community going back to March in terms of the extent to which they can be offering tests, any of the molecular or the antigen or the serology tests to their patients at point of care. And unfortunately, the continuum here between March and now in terms of these authorized settings has not really been all that favorable. Understand that CLIA it's a federal statute. It's called the Clinical Laboratory Improvement Amendments. It's administered by CMS, even outside the context of federal reimbursements. And it applies to all clinical laboratories. And typically, if you're a doctor's office, you may have some type of a waiver which allows you to perform clinical tests in your office. But typically, when you are going to ask for that waiver, you will be telling CMS the specific type of tests you want to be conducting. And typically, those tests are going to be better understood, the technology is better understood, the infections are better understood. And in those instances, if you limit yourself to those types of tests, you can have this type of CLIA waiver. Now, but because of the fact that the coronavirus or COVID is so new, and the science and the medical community just doesn't understand it all that well, or even how to detect it all that well, CMS is not making those types of CLIA exceptions or CLIA waivers available. And so the question becomes, well, I have this pre-existing CLIA waiver because I have this general practice where I conduct tests on my patients from time to time. Can I use that waiver if I want to run COVID tests at my office? And unfortunately, the answer is probably not. And that's based on some of the literature that we're seeing out there. CMS is making clear that they're not issuing these waivers for COVID. And what we're also seeing from FDA, which is taking upon some of the CLIA jurisdiction for itself, it is stating in the emergency use authorizations that it's issuing on a product by product basis where and in what environment these tests can be used. And for the most part, so far, FDA is only authorizing the various tests that are out there for these high complexity laboratories. And but again, we really need to dig into the authorization itself in order to understand where each particular test can be used, whether it needs to be within a CLIA environment, whether we can be using that test at point of care. There have been a few tests so far, including the very notable Abbott one that Joanne's going to talk about, that has been authorized for use at point of care. But so far, what's on the books now, based on the continuum between FDA's March 16th guidance document, its May 4th announcement, and then the May 11th guidance document, followed by another May 21st announcement, is that for the most part, unless the EUA or the authorization says that the test can be used at point of care, you can't be using the test at the point of care, and this needs to be happening, within the CLIA environment. Now, if a high complexity laboratory has a CLIA certification that allows the laboratory to be performing these tests at the point of care, that's okay, obviously, but there would still need to be that that CLIA lab involved. And again, that's what we're seeing as of today. And we'll talk a little bit more about what's out there. Important to note as well that FDA is not objecting to the individual states authorizing labs for testing without federal involvement. And this is, I think, is a very important development and will probably grow in importance over time, especially to the extent that the testing equipment is not being mobilized quickly enough throughout the individual states. But so far, if you're a practitioner in Connecticut, Maryland, Michigan, or excuse me, it should be Mississippi, Nevada, New Jersey, New York, and Washington, your states are working with their own requirements. They're notifying the FDA that they are doing so, and to the extent that you can get this stamp of approval from the state, whether for a particular type of authorization or a exemption, you may be able to use some of these more highly complex tests at the point of care without needing that specific permission from FDA. So again, pay attention to what your individual states are doing. The FDA is not the only player in the room here. And, we'll talk later about some of the other authorities that you can be mindful of, as you wake up in the morning and read the news or try to make decisions on a day-to-day basis. And I'm going to kick it back to Joanne.
Thanks, Andy. So who gets COVID testing at the moment? The CDC updated its guidelines for testing priorities and reporting on the 3rd of May, earlier this month. And they continue to recommend molecular and antigen testing to diagnose acute infections. So they've gone further to prioritize high priority and priority patients for testing above all others, given the apparent bottlenecks in molecular and antigen diagnostics around the country right now. So based on the fact that a lot of these are not available, they're basically prioritizing patients that are in high priority settings, like hospital patients that are admitted with symptoms, and healthcare providers with symptoms as well. What this means is that if you have patients that you wish to test that are scheduled for surgery, for example, a lab that receives your request will typically have to prioritize testing for high priority symptomatic patients in hospitals, healthcare workers, and those who live in close quarters, like in prisons, shelters, and long-term care facilities. So we're going to get right into it. Molecular diagnostic assays are designed to detect the presence of viral RNA specific to the SARS-CoV virus in a sample specimen. This gold standards, and I put gold standards in, it basically involves the amplification of viral RNA by a process called a reverse transcription polymerase chain reaction, or RT-PCR. It looks for the presence or absence of unique genomic markers that are specific to the SARS-CoV-2 virus. So a sample is typically taken from the patient, and the sample is then processed in 3 steps. The first step is basically RNA extraction, usually involving heat, transcription of the RNA into complementary DNA, and polymerase chain reaction to make copies or to amplify the DNA for detection purposes. So currently, RT-PCR tests for COVID-19 generally use samples collected from the upper respiratory tract using swabs. In addition to this, there's also been studies that have evaluated RT-PCR and looked at it from serum, saliva, stool, as well as ocular secretions. So various manufacturers have actually used published sequencing of the SARS-CoV-2 viral genome by Chinese scientists earlier in January to design sequence primers to specifically recognize complementary sequence on the RNA viral genome. What that means in English is that these primers are actually manufactured and used to pinpoint specific genetic targets, which have been decoded from several proteins in the virus, on the envelope, on the spike protein, the genetic code from the nucleocapsid protein as well, which is thought to be more abundant. Once that genetic target is actually identified, the reverse transcriptase enzyme generates a complementary DNA copy of that viral RNA. And basically, once these primers are basically bound to the DNA, they provide a starting point for DNA polymerase to help copy it. So that's like that Pac-Man-like enzyme you see on the diagram here. The DNA polymerase then degrades the bound probe, which results in an increased fluorescence signal with every copy it makes. So if fluorescence level crosses a certain threshold, the test is deemed positive, and if there's no fluorescence at all, the test is deemed negative. So the specificity for RT-PCR tests is quite high because the primer design is specific to the genome sequence of SARS-CoV-2 and increases when the test uses detection to maybe more than one target site on the virus itself. Limit of detection for RT-PCR tests will tell you the minimum amount of RNA that a test will need to detect virus 95% of the time. So the limit of detection, therefore, provides a sort of an overall sensitivity of the test and varies really depending on the commercial manufacturer, the kind of the type of specimen they submitted, such as saliva or nasal swabs. The good news here is that most RT-PCR tests allow them to detect at least early infection. That is, obviously, if the sample's collected properly and isn't compromised. So while RT-PCR is currently the gold standard, some limitations actually exist. In most individuals with symptomatic COVID-19 infections, viral RNA collected in nasopharyngeal swabs become detectable as early as day 1 of symptoms and peaks within more or less the first week of onset of symptoms. This positivity starts to decline roughly by week 3, and subsequently it becomes completely undetectable. Obviously, there's outliers to that as well, but that's the general rule of thumb. So the timing of this test is therefore key to diagnose active infections. So RT-PCR can determine if there is an active infection, but not whether a patient has previously had the infection some time ago. So whether positive or negative, the PCR test is really only indicative of whether the virus or fragments of the virus are present at the time the test is taken. So false negative results can occur due to inappropriate timing of sample collection in relation to when the symptoms actually presented themselves. So RT-PCR basically currently doesn't rule out whether a patient is at a very, very early stage of infection and therefore where they will show symptoms in the future. That's why, there's a lot of groups that are basically looking to repeat tests on a recurring basis, and to combine these tests sometimes and confirm them with CT imaging. So false negatives obviously are a big issue here, and I'll kind of go into that further. They've been also seen, obviously, due to a lot of deficiencies in the sampling technique, especially when using nasopharyngeal swabs. So the technique and jamming a swab up someone's nose seems to be quite key. It's actually thought that as many as 25% of nasal swab tests are likely false negatives, which may be caused by, improper collection, also improper handling or the storage of the sample on the way to the lab. Oftentimes, false positive or negatives can actually occur when there's too much time elapsed between collection and testing. And also it can be down to lab error, which can happen. So RT-PCR is also time and resource intensive, and it requires expensive and really highly complex lab equipment. And it typically takes anywhere from 45 minutes up to 4 days, depending on how busy a lab is. So the current run on reagents and collection equipment like swabs is also affecting capacity in several countries around the world, not just here in the US. So the longer processing time, the high demand on these testing kits, and the ancillary components like these swabs that are needed for sample collection and preparation are causing a serious bottleneck for this testing method. So I wanted to sort of discuss a highly publicized PCR device called the ID Now, which is actually made by Abbott. This device is actually used in the White House to test staff and utilizes isothermal nucleic acid amplification rather than temperature-dependent RNA extraction. And it provides positive or negatives at the point of care. It's EUA approved, and it basically provides positive results in 5 minutes and negative results in 13 minutes. The FDA issued an alert on May 14th, which informed the public about a higher rate of false negatives without ID Now versus the Expert Express, which is another RT-PCR system, which is also EUA approved for point of care testing and therefore waived by CLIA. So this study was performed here in New York at NYU Langone and observed that the ID Now test missed a third of samples detected by positive by the Expert Express device when they used nasopharyngeal swabs in viral transport media. It also had a very, very high false negative rate when dry nasal swabs were used. So 48% of the samples actually were negative with dry nasal swabs, which is actually quite weird because the Abbott IFU actually calls for dry nasal swabs to be used. So the FDA has apparently received 15 or so adverse events reports about this ID Now device regarding false negatives. So, all in all, the bottom line here is that even with, an EUA approval and the current understanding, on all these devices being gold standard, molecular devices, as with, anything in, orthobiologic cell counters, are never created equally. So you need to kind of evaluate the device performance. And now we're going to talk about serology testing. So COVID-19 infection can also be detected indirectly by measuring a patient's immune response to the SARS-CoV-2 virus. So serology tests are therefore created to basically pick up IgM or IgG or both in a patient's blood that has been previously infected by the virus. So antibody testing or the use of immunoassays are not at the moment recommended for routine COVID-19 diagnosis per the CDC on a standalone basis. So they should always be used in conjunction with others. Serology testing is also becoming obviously a very important part or an important tool for public health officials to kind of understand the extent which COVID-19 is present in various communities and populations around the country, as was identified in LA County and New York State studies. Both of those studies basically were looking to determine seroprevalence of the disease. So seroprevalence basically helps to identify if small or large swaths of the population have been exposed to a virus. When there's a large population that's been exposed, that's called herd immunity. The New York study actually showed that about 15% of the population had been exposed, and conversely, 4% of the population were quantified in the LA County study. So very small percentages of people in the US have been exposed. So we're a little bit far away from herd immunity at the moment. Right now, there's not really enough evidence to support that the presence of IgG antibodies to COVID-19 provides long-term immunity to the illness, although more and more people are basically assuming that infectiousness is greatly decreased if you have IgG, and that some degree of immunity will be garnered for future infection if developed. So Generally, these serology tests are typically less reliable than RT-PCR molecular tests, but they can be performed at the point of care and community settings without the need of expensive equipment and long wait times. There are really two main types of serology tests available right now: ELISA assays and lateral flow rapid tests. ELISA, or also known as enzyme-linked immunosorbent assays, are a sort of plate-based assay technique, and they're basically designed for detecting and quantifying substances such as, peptides, proteins, antibodies, hormones. We actually often characterize, growth factors from PRP platelets using this technique as well, as some of you may know. The tests from serology can be qualitative or quantitative. The time to result for ELISA typically, takes about 1 to 5 hours. So in the case of SARS-CoV-2, the plate wells are basically coated with viral protein. If present, antiviral antibodies in the patient sample will bind specifically to these, and those bound complexes of antibody viral protein can be detected with tracer antibody that produces like a color or a fluorescent reading. So it's a speedy-ish test, and some automated devices have the ability to test a large number of samples at a time. So an advantage of immunoassays really right now is that, can also provide like an estimate of where the patient is in terms of their disease stage, whether they're acute, early, or whether they're convalescent, since ELISA results can typically provide a titer in combination with obviously RT-PCR confirmation. So there are several additional advantages of using immunoassays, like assessing, the immune status of healthcare and other sort of essential personnel. You can assess convalescent plasma. ELISA can be used to, evaluate vaccine efficacy eventually. And you can also identify low-risk individuals to go back to work with ELISA. Conversely, rapid serology tests, which you see here on the right-hand side, are typically qualitative. They're chromatographic assays that are small, they're portable, you can put it in your pocket, and they typically are designed for use at the point of care. These rapid test devices basically provide a positive or negative result in more or less 10 to 20 minutes. Their lateral flow rapid tests don't really require expensive lab equipment. They're pretty inexpensive for the most part. We've heard a wide range of, test prices on the market recently. Our tests are actually also marketed by groups like Cardinal Health. They basically sell the same test as we do, and they're typically selling it for about $17 to $18. So lateral flow cassette devices require very little, very little training. The IFU is really simple to use, but they really only provide a qualitative result. So here's how they work. The concept of this test is a little bit similar to like a pregnancy test. They normally rely on lateral flow assays with simple like cellulose-based devices that are basically intended to detect the presence of an analyte in a liquid sample. So you drop blood, you put some buffer, and it basically carries that analyte, if it's present, across that assay. So they make use of also of the antibody antigen recognition using monoclonal antibodies to detect viral antigens. So these test strips that you see here on the top right-hand side are basically bound with antibodies to a viral protein. So if a patient sample contains those proteins, they will bind to the antibodies and they'll form a colored like indicator on the strip. Colloidal gold nanoparticles are typically, what produces that color. And so they're the most commonly used material to induce like a change in color in the presence of a certain analyte. So there's several advantages of using serology tests at the moment with regards to, urgency. The COVID-19 IgM, IgG antibody test can really provide like a presumptive qualitative result at the point of care really quickly. This provides obviously healthcare workers with a lot more information at critical care moments, like in the patient's care. Given that these tests are really low cost and they provide a fast turnaround time for symptomatic patients, they can really reduce the burden on hospitals and labs and clinics. And even employers, like basically if timed appropriately upon triage of a patient. Also, recovering or recovered patients can use COVID-19 sort of antibody tests in conjunction with negative RT-PCR tests to confirm recovery and the existence of virus-fighting IgG antibodies in the bloodstream. So the performance and accuracy of these tests is described by their sensitivity or their ability to identify those with antibodies to SARS-CoV-2. And that's also known as the true positive rate. Specificity is described by the test's ability to really identify those without antibodies to SARS-CoV-2, and that's also called the true negative rate. So as far as the test sensitivity, it can also be determined whether or not or can detect the antibody in blood samples from patients who have confirmed COVID-19 with positive RT-PCR tests. So there are a lot of questions about the sensitivity and specificity of these tests right now, and I see a lot of questions on the right-hand side here. People want to know if they're getting, the right thing. The FDA.
I'll get into some of that as well.
Yes, please. Yes,
okay.
Please.
All right. So you want to keep moving?
Yeah.
Great. So I think you may have covered. Yeah. All right. So again, for these, we have a couple of questions already relating to serology testing, and apparently CDC made an announcement today that the serology tests are inaccurate up to 50%. First of all, I hadn't heard that. Secondly, it doesn't surprise me at all. And thirdly, again, this is an example of why we really need to be monitoring everything that's being pushed out, both by the scientific community and the government agencies on a daily basis to understand what's out there. But again, it doesn't surprise me, and it doesn't surprise me because we've been tracking everything that's been happening within FDA. So on these serology tests in March, the FDA announced that there were no EUAs required for the serology tests. But at that point in time, if you did want to market a serology test in the United States, you needed to validate your device, and you needed to notify the FDA that you were doing so, and you needed to include qualifying labeling along with the serology test, basically telling the healthcare provider and the patient that they cannot rely on this serology test for purposes of understanding in an absolute sense whether the patient it has COVID or is immune to COVID, et cetera. So, that's from the beginning. And in the beginning, they also announced that, that these serology tests could be used by healthcare workers at the point of care. Now, it's not until March that we see FDA reversing that position a little bit. And by the way, in case you care, FDA really has that discretion right now to make policies and reverse policies. So to the extent that you make a large investment on whatever type of technology it is today, chances are FDA may pull back on that in the future. Again, another good reason why we need to be monitoring these developments on a daily basis. But ultimately in May, or on May 11th, the FDA says, well, we've got this long list of serology tests These companies have notified us that they're marketing them in the United States without having the emergency use authorizations. You've got 10 days to submit your EUA application. And on May 21st, which is 10 days later, FDA announces that there's 29 of these serology tests were being removed from the marketplace because they hadn't submitted those EUA applications in time or on time. But that, as of this point, and today's again May 27th, there are still quite a few of those serology tests that are still in line. They notified FDA in the beginning. They submitted their EUA applications on time. They can theoretically be used now in the United States, but FDA is also making clear in its more recent announcements that for those tests that have that have notified but don't have the EUAs yet, those are not available to be used at the point of care. They can be used within the the high complexity CLIA environment, but not yet at the point of care. So I think that what CDC is saying about these tests might be consistent with this sort of back and forth that we're getting from FDA as of this moment. But again, there's a number of these serology tests that are in the queue. They've submitted all the necessary information to FDA. We're waiting for those EUAs to start getting pumped out by FDA on a test-by-test basis. But we really also need to see those EUAs for purposes of understanding the where or in what environment those serology tests can be used. Again, right now, the default is that if it's a serology test, it's notified the FDA and it's submitted the EUA application, it can be used, but only within that high complexity CLIA environment and not at point of care. We will need to see those emergency use authorizations and the details within them to understand whether a to be approved or a to be authorized serology test will be available for use at the point of care. And the jury is still very much out on that, and we're waiting to hear back from FDA, and hopefully by that point we'll have a better understanding of what the marketplace actually is for some of these serology tests. So that's where we are now. So I think I've answered two of those questions relating to CDC's announcement today. I've got a couple of other questions, and we'll get to those as they come up based on the subject matter. And I'll go back to Joanne for some other options on the market for COVID testing.
Yeah, I just wanted to make one more comment on like the drawbacks of serology tests. I wanted to talk about predictive biotech, and one of the reasons that actually spurred the FDA to basically change or reverse their initial guidance on using these serology tests with healthcare providers at the point of care is that the market was basically deluged with, all different types of tests. It was basically a free-for-all. And a lot of these tests even passed muster in the countries of origin that they came from. So a lot of Chinese tests came on the market, FDA basically tried to put a stop to it because they wanted to be sure that they were, protecting Americans. They've also basically changed their sort of guidance on manufacturers to have a certain minimum sensitivity and specificity for these tests most recently. And we're basically following those very, very, very closely because we want to be sure that, any tests that we basically decide to sell to our clients meets those guidelines or exceeds them, especially given the fact that there's a lot of drawbacks, a lot of limitations to serology tests across the board. So I think there was a comment that basically said, like, how can CDC combine like 50 of these tests in one pot? There's actually 200 plus counting. So there's all kinds of different tests on the market right now. And, our tests that we've been selling so far have, in my opinion, very, very high sensitivity and very high specificity as well. And I'm happy to share that information with you. But let's move on because we're running out of time. Antigen testing. Antigen testing can detect basically the presence of viral proteins that are part of the SARS-CoV-2 virus. They're very specific for the virus, but they're not as sensitive as molecular tests. So negative results from an antigen test may need to be confirmed with a molecular test or RT-PCR prior to making decisions and help prevent the spread of the disease further. So antibody tests basically use a nasal or a throat swab to detect viral proteins expressed on the outer surface of the coronavirus. So antigens are basically another word for it is a foreign substance. They're like a virus or a bacteria. They're recognized by the body, and they basically induce an immune response to fight off the infection. So in theory, these tests can be used to diagnose individuals infected with the virus, but only one test has received EUA approval from the FDA earlier this month. It's called a Sophia 2 SARS antigen. It's made by Quidel. Basically, it's a lateral flow immunofluorescent sandwich assay described here on the right-hand side. Basically, you need a little tabletop device to read it. So its indication for use is for the qualitative detection of a nucleocapsid protein antigen from SARS-CoV-2 from a nasal swab. So the EUA approval applies to moderately and highly complex labs, but also it can be used at the point of care. So these tests are typically cheaper than molecular tests or RT-PCR, for example, but they're more expensive than lateral flow cassettes. So the limitations on these are that typically, the antigen doesn't really differentiate between SARS-CoV or OG SARS, what we call it at Plymouth Medical from 2003, and SARS-CoV-2 viruses. So cross-reactivity and false positive are to be expected here. So the antigen testing has more or less the same limitations as RT-PCR in terms of false negatives, basically given the timing and the sample collection and the issues with transportation if you're not testing at the point of care. So it's really sort of recommended to test antigens as quickly as possible. So this test, the Sophia test, is basically a sensitivity of 80% when compared to positive RT-PCR molecular tests. So by comparison, just for information, strep tests are more or less 85% sensitive. Flu tests are more or less 60%. So just gives you kind of a comparison of what we're dealing with. And now onto home use very briefly. So the FDA has basically recently announced emergency use authorization and approval of testing kits that really permit patients to harvest their own samples at home. Everlywell's test received an EUA approval mid-May. Despite being embroiled in a very public battle with the FDA earlier in March, as they early released their kits for home use prior to EUA approval. And the FDA took offense to that and basically changed a lot of the labels for other tests that they were specifically not made for home use. So the EUA approval letters for Everlywell basically involve a triage of patients. They use a network of telemedicine providers, and they basically route samples to specific labs that will run RT-PCR tests on the samples that have been sent in. It doesn't, seem to be available yet for purchase, and they've kind of left it for frontline workers and healthcare providers as a priority. But basically, the sample swab is provided to patients to harvest their nasal sample themselves and to ship it back in a collection tube filled with saline. What's interesting here is that the FDA basically in 2016 had a panel that they basically examined home use test kits for like HIV and flu and strep. And at the time, the agency basically determined that nasopharyngeal swabs, such as the ones that are being used right now, weren't reaching deep enough in the nasal cavity to get a result, and therefore mostly ineffective in the hands of untrained users and patients.
Well, it's funny, Joanne, because at a lot of the testing sites, the workers don't want to get too close to the people in their cars, so they're handing the nasal swabs to the, to the patients, to the people in their car seat, and saying, "You do it." And so
Yeah.
it's like, how much of an appetite do you have to stick
To
this thing
jam
all the way up
swab up your
brain?
nose. Yeah.
Yeah.
And we all know, I mean, we covered that in the limitations of RT-PCR tests. Like if you don't do it properly, you're going to get false negatives, right? So, but this company seems to be very well funded. They have received FDA approval or EUA approval for their home tests based on data that they leverage from the Bill and Melinda Gates Foundation and United Health Group. So, while 25% of, doctors might not be able to collect, appropriately, it's the jury's still out to see whether patients will be able to do so. Obviously, there's other home kits as well. There's a Pixel by LabCorp that is no upfront charge for patients. There's also a Rutgers group that basically has developed a saliva-based collection, which obviously, patients can't mess that up. So, interestingly, New York seems to be a problem state. New York, New Jersey, and Rhode Island won't allow for any home testing. So if you're in those states, you can't get access to those kits. Patients with, mild or really, really severe symptoms will be excluded and basically be sent to the hospital directly. This is a very brief chart that basically demonstrates sort of the detection time over time for various tests and the sample of origin, and basically relates that to system onset or symptom onset rather. You'll find this in our resource guide on our website if you want to look into it some more with the sources on all of this as well. I'm sort of conscious that we're running out of time. So as far as, office-based protocols or OR-based protocols, I thought this was a really good diagram here, which was taken from the British Journal of Oral Maxillofacial Surgery. It's like an if-then protocol. I think we're going to see a lot more of these basically published. We're working with a group at the moment in developing if-then protocols for RT-PCR, ELISA, serology tests, and rapid lateral flow devices, so that our clients can basically, depending on the context, whether it's pre-surgical, pre-procedure, or just generally for their employees, return to work and emerge from the pandemic. So we'll keep you posted on that, obviously.
Okay. All right. So just to summarize, I think, you've gotten the point by now about what's out there. I'm not going to belabor this one, but again, understand that there's no FDA approved COVID tests. They're authorized, but they're not approved, and they haven't gone through the same regulatory process that they would go through outside of this public health emergency. So just, take everything that you see as far as these tests is concerned with a real grain of salt. So moving on, understand that there's also been lots of enforcement that's been out there. Yesterday there was another criminal prosecution that was announced in the Southern District of New York in federal court. And really what we're seeing is, well, first of all, a lot of knuckleheads who are, making different types of products that were never designed to be related to COVID before, but, they're seeing this market opportunity and they're taking advantage of it. So we've seen all sorts of different warning letters from really hundreds of warning letters at this point from FDA and FTC towards dietary supplement manufacturers and CBD companies and kratom companies that are now advertising their products to be helpful in either the prevention or the cure of the coronavirus. So when you see that stuff, just be mindful that FDA and FTC are really on the warpath as it relates to a lot of those guys. But at the same time, we're also seeing a lot of device distributors, or I guess people who are now device distributors who were never involved in the medical space before. And in certain instances, they're selling products that they don't have. In other instances, they're taking payment for products that they don't have, and leaving the purchaser high and dry. There's a lot of price gouging that's out there. And again, this is really one of those places where you want to understand who is on the phone when they reach out to you. If they're sending you a fax and you've never heard of them before you make an order, do some vetting, do some due diligence to understand what is this company's pedigree, what's the supply that they say they have, what's the regulatory status of the products that they say they have, etc. Simply because this is really it's unfortunate, it's tragic, possibly it speaks to the human condition, but we're seeing a ton of this right now, and it's pretty upsetting. So just be sure to have your antennas up and understand that if you've never heard of this person before, you've never heard of this product before, don't take anything for granted. Do your homework before you take out your checkbook. Now we'll move into getting back to work, because I understand that we've got some questions about this one as well. What are the best practices that we can employ in terms of reopening our medical practice after having been closed for a certain amount of time? And really, there are no clear answers here. There's no clear authorities, subject to some important exceptions. But really what's happening now is that you've got to use your best judgment as a licensed medical practitioner in terms of when you're going to be reopening, how you're going to be reopening, what types of tests and other equipment you want to be employing, what are the additional questions that you want to be asking of your employees and your patients, etc. This is really a judgment call, and it's an important judgment call. And understand that there are different risks out there, and there's no clear static answer across the board. If you're working with patients who are immunocompromised, that may require a higher level of protection than if you've got a general practice. If you have lots and lots of people working for your practice, that may require other steps that a much, much smaller practice may not necessarily need to take. But understand there are real risks out there. And I'll give the hat tip to Chris Centeno with Regenex. In one of his blogs from last month, he talked about a report that came out of China, which discussed 34 non-COVID patients who received routine surgeries in Wuhan between January 1st and February 5th. All of them developed COVID. 44% required ICU care, and 21% died. So there are risks out there as far as performing even routine procedures on your patients under these circumstances. And also understand, as we've been discussing all along today, the devices, the diagnostics that you've got right now or that are available to you, even the gold standard is not necessarily perfect. So again, you've got to be mindful of all of these issues. Now, the one thing that I can assure you is that if you want to stay protected, understand the rules that are in place for your particular jurisdiction. And if you're in Miami, Florida, you need to understand the rules from the top down, from the state government to the county government to the city government, and understand that if there is a prohibition on these elective procedures, and you perform one of those elective procedures during that time and somebody gets injured, there are risks for that. There may be reputational damage associated with it. It may be an easier case against you down the road as far as malpractice is concerned. So that's the one place where I can say for certain is that you have to understand what the rules are. But beyond that, in terms of what's going to happen within your medical practice, most of that is going to be within your jurisdiction as the licensed physician. Going into all of this, have a plan in terms of dealing with all of this. Perhaps you want to delegate this to somebody, to an office manager, something like that, and they're in good communication with you. That's fine, but they need to understand what they need to be looking out for. And again, don't take anything for granted. Can I reopen my practice for all intents and purposes, if I don't necessarily have a good supply of of personal protective equipment and other supplies, I don't know. That's something you need to answer. What will you do in the event of an infection? Let's say one of your employees comes up sick. Let's say it turns out one of your patients was sick. What is our plan? What are we going to do? And theoretically, there's some middle ground to explore here as well. Do you need to reopen all at once? Or is it more appropriate to address the highest priority patients and procedures first, and then let those less essential, and it's not to say that the procedures that you offer aren't essential for all of your patients, but someone with a more acute condition, someone who's suffering in more pain, who can't go about their day-to-day lives because of the pain that they're in, okay, let's deal with them first so that we don't have to have a crowded office, so that perhaps we don't have to invite all of our employees back to the office at once. And again, make these step-based, risk-based decisions so you're not biting off more than you can chew. And you'll see here, I've got two slides. Workplace safety is patient safety, and then the next one, patient safety is workplace safety. And they're all related. As far as workplace safety is concerned, your people need to understand what your expectations of them are. And you need to be the one, as the doctor, setting these expectations and making sure that everybody understands. And consider putting a policy in writing where you're telling your employees what they have to report, when they have to report it, including have they been around somebody who's recently been diagnosed? Do they live with someone who's more at risk for contracting the coronavirus, like another healthcare worker or like an OR worker, etc.? There are lots of these different options that you have to have in mind, but it's got to start from the top. And it needs to be the physician who's setting these priorities and making the rules, understanding that a lot of the prohibitions in terms of what we can, the types of questions that we can be asking our employees right now are out the window, because we have to make a decision, a risk-based decision for our own practice. So asking these questions about who's your husband, who's your wife, where do they work? It's not necessarily inappropriate under these circumstances. And some of the federal agencies that regulate this sort of thing have really taken a more flexible approach to all of this, including the employer's handling of the protected health information of the employees. So you can make more aggressive decisions as far as those questions that you ask, so that you can maintain a safe workplace, again, which is relevant to you, it's relevant to your workers, and it's relevant to your patients. And the same thing applies for your patients. We don't want to be bringing a sick patient, someone who's possibly has the coronavirus, into our office, particularly for a surgery, even a routine surgery. So the best recommendations that are out there separate, to the extent you have to have sick and well patients come in, set yourself up like a pediatrician's office. You're going to have a sick wing or a sick waiting room and a well waiting room, and we want to keep these folks as separate as possible from one another. Telemedicine has become extremely prevalent. Jessica's going to talk about the doctor.com tool at the end of this webinar. Use it. And right now, based on CMS guidance that's come out, there's a lot more flexibility in terms of the types of technologies that you can use to conduct these telemedicine consultations with your patients. Right now, if you want to use Zoom, go ahead. If you want to use FaceTime, go ahead. Whereas ordinarily, under the HIPAA rules, that might not necessarily be appropriate. But understand, beyond anything else, that communication is critical, and your patients should understand what to expect when they get to your office, so that there's not going to be a fight about whether they have to wear a mask. There's not going to be an argument when you tell them that that their friend or their husband or wife can't come with them, and it can only be them in the office. And there's not going to be any friction when you screen them at the threshold. You're going to be asking them to fill out a questionnaire. You're going to be taking their temperature, theoretically, that could be offensive to some people. So make sure you're communicating that information in advance. Beyond that, if you are going to be conducting these procedures, again, understand that there is a significantly heightened risk associated with getting a procedure now as opposed to in the ordinary course. So consider whether additional informed consent is warranted to address that risk and to make sure that the patient understands going into the procedure that he is at a heightened risk of contracting the coronavirus, and you let him make the decision. Additionally, to the extent that you are offering testing at your office, if somebody has tested positive, if there's a maybe, I'm going to refer in a few minutes to some of the other authorities that are out there. But if you look, for instance, at the Florida Medical Board website, there's all sorts of information that you can print out and hand to the patient so that they understand what to do, how to self-isolate, what type of additional care may be warranted, etc. And your patient should also understand that you might be under an obligation, depending on your state law, regardless of their consent, to report positive and sometimes negative test results to state health authorities so that they can conduct the tracing that might be necessary to make sure that that your patients haven't infected a large number of other people. That is
and
all.
what we've seen there, Andrew, is that, that will really, they're on the reporting that will really vary from state to state.
Yes.
So we have a sort of a tool on our website where people can go in and kind of dig deep at state and county level, even what the reporting guidelines are. Like New Jersey, you have to report all results. New York, there's a form to fill out. And other states, there's a web form. So it's kind of a minefield out there. So we've just tried to provide as much information as possible on our site to help.
Okay, so let's keep moving on. And by the way, before I move, I got a question from earlier on. Many local facilities are requiring testing prior to performing elective procedures. Have there been any federal or state mandates as to the type of test that's needed? The answer is no. I'll type that in here. We don't have that type of authority yet. And I think any government agency at this point would be hard pressed to order a specific type of or require a particular type of test, just given, again, the fact that the technology that's out there is not necessarily all that reliable as of now. But what I can say is that we do need to be looking at the authorizations that some of these tests have to understand whether they can be used at the point of care, or whether they need to be conducted, within that more high complex CLIA environment. But again, if you walk away from this webinar understanding one thing, and that one thing is that this is a fluid situation, and you need to be paying attention, and you need to be asking questions, I think we've done our job. And so, just to tell you, for my own benefit, my own legal practice, there are a lot of resources that I'm paying attention to, and I'm paying a lot more attention to some of this stuff than I ordinarily would. CDC is one. If you want to understand what a NIOSH approved face mask respirator looks like, what the markings are going to be for that NIOSH approved face mask, look at the CDC's website. They have information about all of that, and they'll also have information about the devices or about the face masks that don't have that NIOSH approval. And CDC they're also making recommendations about workplace safety in the ordinary course that we may want to pay attention to as well. Not necessarily even for our own medical practices, although that's available as well. But for some of the other places where our friends and loved ones might work. Again, the emergency use authorizations themselves are critical. We can look at the emergency use authorization and understand the technology behind the device, where that device is allowed to be used, and then together with those EUAs, there are fact sheets for patients and for healthcare providers that can also be very informational and helpful, and you should be mindful of those as well. Again, state health departments are also critical. They're providing certain levels of guidance, both for the general public, and the medical boards are providing guidance for medical practices. They're providing handouts for patients. You can see there about the different types of licensing flexibility that's available. So if you're licensed in New York and you happen to be living in Florida right now, quarantining, the state of Florida may provide some additional flexibility for you. But again, that's something that we need to be looking at on a case-by-case basis. The American Medical Association has a ton of guidance that's available, a whole guide for reopening that you can review for certain best practices. Same with EEOC for the application of the Americans with Disabilities Act during a pandemic. One of your employees comes up sick. What can you do with that person? Can you require him to work from home? Can you terminate, etc.? Again, there's a lot more flexibility in these rules now than in the ordinary course. Finally, OSHA, which is the federal regulator for occupational safety. They're going to have resources that are going to be available for all sorts of different companies to abide by, or at least to understand. And so that's another resource you can look at. And finally, something that you may not be mindful of, but should be, is your insurance policies. If you reopen now, are you going to be at a heightened risk of malpractice? What is your insurance company going to be saying about that? Perhaps you should be having a discussion with your broker, and theoretically, rather than the medical malpractice coverage, your general liability policy might be kicking in here as well, to the extent that somebody comes into your office, doesn't necessarily receive a procedure, but gets sick anyway because, let's say, you haven't done enough as far as separating your sick patients from your well patients. And finally, just as an aside, take a look at your business interruption coverage. To the extent that you may have been forced to close for a certain amount of time and you lost profit as a result of that government-enforced closure, depending on where you are, there might be insurance available for you. So be sure to take a look at that. And there's guidance that's out there. I've written some articles on my website about the different clauses you can be looking for in your business interruption policy, all of which can be critical right now and to help you make the best decisions going forward. So I'm just going to see if there are any questions that haven't been answered. I think between Joanne and I, we have. If there are any other questions, I'm obviously happy to take them, but I think that's it for Joanne and I at this point.
Thank you, Andrew. Thank you, Joanna. That was super valuable. And thank you for the participants for asking such great questions. It's definitely helpful. I know we're a little over time, so I'm going to take 20 seconds to just remind you guys about the doctor.com virtual visit platform. We are launching robust features pretty much like bi-weekly for the next 2 months in terms of what's coming out. But right now we have it's HIPAA secure, and it's HIPAA compliant, it's secure, it's HD, it's really easy to use, and one of the best features right now is that you don't have to log in or sign in. And as Andrew mentioned, this is a time for us to think about different ways to communicate with our patients and screen them and separate some of the patients and try to avoid having them come to the practice if it's not absolutely necessary. And with Zoom and a lot of these other platforms out there, as soon as these regulations and laws are lifted, you're not going to be able to have that flexibility. And often they charge money for some of the features that we offer that are complimentary. We actually just had a press release this week on how we launched the review request feature. So at the end of every telemedicine visit, the patient will be automatically prompted to leave a review. And we're the only telemedicine platform that has been able to add that feature seamlessly, and then also have that one review go to over 8 sites for you. So in terms of virtual visit, you want something that your patients and your staff could get used to. You want something that will stick around. And as we went through some of our telemedicine survey results in terms of patient adoption, their biggest fear was having to learn how to use a new system and remembering passwords and whatnot. So if you have something that you could use for the long term, it'll be a great experience for your patients. And being able to have that access to patients even out of your geographical state is great, and a great way to help increase your net revenue. So thank you, everyone. I really appreciate it. If you have any other questions, let us know. And if you need to get a hold of Andrew or Joanne, we do have their information here on the chat, or you can reach out to us and I'll be happy to connect you with them as well. All right. Well, thank you, everyone. I appreciate it.
Everyone.
Thank you.
Have a great rest of your day.
All right, everyone.
Bye.
Bye-bye.